So here is the muscle layer. You see, we cut the muscle and then close this defect. Because in Hirschsprung disease, what happens? The muscle becomes very spastic. So because of the spastic nature of the muscle, the patient has obstruction and cannot pass stools. So if you cut the muscle, then the spasticity goes, and usually the patients. So what we put together, because there are not large studies available, only few case reports are available by the Pune group, Dr. Amol Bapaya. So this procedure is conceptualized and has been done in India, and Dr. Bapaya. After this, everyone has started doing this, but again, these cases, the incidence is also Hirschsprung disease, we don't see every day. So this is a very novel procedure for this disease. Now this is another procedure called poetry. This is for complete esophageal obstruction. So here what happens, suppose there is a complete esophageal obstruction, you cannot, but this has to be less than 3 centimeter for this procedure. If the esophageal obstruction is more than 3 centimeter, this procedure you cannot do. So what we do is here again, submucosal tunneling you do with the endoscope, submucosal tunneling you do and come inside. Then there should be another retrograde endoscope which is done usually placed by gastrostomy. So after doing this submucosal tunneling, the guide wire through the submucosa comes out into the mucosa, and we can see with this scope. So once the guide wire, the other scope comes from submucosal tunneling here, then we put a guide wire, and over the guide wire we put a stent. So after that, there is after this stent, you can remove the stent, and usually the lumen is restored, but this is only a case series of 4 patients is present. There is not enough literature for this procedure, but even that in 4 patients, again there was luminal occlusion in 1 or 2 patients. So we have to wait for this procedure, but this we should keep in mind that this is an endoscopic procedure with which you can treat complete esophageal obstruction if these patients are not fit for surgery. Now, talking about side effects, insufflation related adverse events are the most common, like emphysema, all these patients' PREM. So 3 things before doing PREM you have to see. First and foremost thing, the air should not be used. Again and again you have to check with your technician that the air is off and carbon dioxide is on. Because if you do the procedure under carbon dioxide, you are safe. Then of course the other complication is perforation and bleeding. So these are few complications which has been reported, like you can see this carbon dioxide, so this is the capnoperitoneum, you can see air over the liver, carbon dioxide over the liver. And the second is you can see the kidneys. So this is retroperitoneal carbon dioxide has seeped, and you can see this retroperitoneal collection of carbon dioxide around the kidneys. Here you can see in pneumomediastinum, that is capnomediastinum, where there is a lot of carbon dioxide accumulation in the thorax. This is the perforation, which we talked about, mucosal perforation. Here if you see the esophageal lumen, there is a lot of hyperdense, there is bleeding inside the lumen. So this is the bulge. So sometimes bleeding can occur late, bleeding can occur, delayed bleeding, where we have created the tunnel is loose, suppose some blood vessels they start oozing, or you have not achieved complete hemostasis, there can be a bulge in the lumen, and this is how most of this bleeding, hematoma, if it is not actively bleeding, you can leave, body will absorb this, but if it is actively bleeding, then you need to intervene. So luckily the incidence of severe adverse events are there, and there are some predictors of adverse events on multibright analysis. You should expect side effects in which patients, adverse patients. If there is a sigmoid type of esophagus, then the chances of complications are more. If the endoscopy experience, when you start learning, if you are inexperienced, have done less than 20 cases, there can be complications. Then use of TTJ knife is associated with more complications. And use of an electrosurgical current other than spray coagulation, because if this electrosurgical current, there are 3 types: spray coagulation, there is pure cut, and there is forced coagulation. So if spray coagulation is the safest one, because with spray coagulation you can achieve hemostasis also. Then these are other adverse events like delayed mucosal barrier failure may occur after PREM, like as I said, the mucosal flap valve, sometimes there can be perforation. Endoscopic or surgical repair along or without chest tube drainage is mandatory if there is an infection, mediastinum. So because if there is that flap valve mechanism, if it is lost, if there is mucosal barrier failure, then usually there is a chance that the mediastinum might get infected. Delayed bleeding luckily is only 0.2 to 0.7%, and aspiration pneumonia, these are always there with all endoscopic procedures. And adverse effects of star has been reported from 0 to 42%. In a large study of 290 patients, the overall incidence was 23%. Mucosal injury, major bleeding, pneumothorax. And what I'll tell you, these complications which are there in the literature, these were all initially reported. Nowadays, as experience, we are gaining the side effects or the adverse events are very, very less. So this is one of my patients who had a delayed bleeding. As you can see, this poem we had done in the morning, and at night my resident called and said the patient had a hematemesis. So that's the nightmare in a patient of poem if they have hematemesis, what to do. So we didn't do anything at night because the patient was hemodynamically stable and the hemoglobin also didn't drop much. Morning we did an endoscopy because again you have to intubate the patient. We cannot do endoscopy without intubation in this patient because the more the rage, the more bleeding will occur. So as you can see the clips, this is our own patient, this is clips you see, and from the clips some blood we could see here, it was oozing, see blood coming out. So what we did was we took out all the clips. We had to intervene in this patient because the patient was actively bleeding. By the time we did endoscopy, if the bleed would have stopped, then we would not have intervened. But there was not much HB drop though, only 1.5 or 1 gram drop was there. But still, because in endoscopy we saw active bleeding, we had to intervene. So we took out all the clips. It's very easy to take out the clips. With the rack tooth forceps, if you just catch hold of the clips, they will come out. And we entered the tunnel. This is the tunnel. You can see a lot of clots inside the tunnel. You can see the tunnel, lot of clots. So these clots we had to take out. So with rod net, then with snare, then with rack tooth forceps. So it is a tedious job. Took almost 45 minutes, 40 minutes to take out all the clots. And after taking out all the clots, we could spot a sputter in the muscle. So inferiorly, where we had cut the muscle, there was a sputter. So we have a forceps. This is a forceps. With the forceps, we can catch hold of the sputter, and we stop the bleeding. We achieve hemostasis. Then we closed. So you can see the sputter. It will come. Yeah, this here. Inferiorly, see. You can see here. Just here. Here was the sputter. So this is the hemostatic forceps. With that, you catch hold of that sputter and you can cause coagulation of that. So after that, we came out, we closed the defect, and the patient was doing well. The patient didn't bleed after that. So now coming to the most important aspect, training in third space endoscopic procedures. The learning, so there are various studies which have described training. So learning curve for POEM has been reported from 7 to 100 cases. Patel et al. Has reported that POEM efficiency is achieved at 40 cases, where mastery is achieved at 60 cases. Albi et al. On the contrary reported that 25 procedures are required to achieve competency. And there was another large series of more than 1,300 patients which recommended a minimum of 100 procedures performed under supervision to attain proficiency in terms of reducing the risk of technical failures, adverse events, and clinical profiles. And hands-on training is very important. So there was a study even with the hands-on training where they showed that on the basis of the questionnaire conducted for 116 participants among the doctors, 25% of the attendees could successfully perform ESD and or POEM within 6 months of hands-on workshop. So initially we learned all on pigs, so you have to do POEM, ESD in pigs, pig model. So after doing that, around 25% of the doctors were able to start their cases of their own. So you get the idea, though you don't have this bleeding and all in these models of course, but you get an idea, the depth, the perception, how much to cut, how to use the accessories. So it's important, very important. Before starting on patients, the hands-on training on animal models is very important. So to conclude, third space has emerged as a novel operating field for interventional endoscopies with consistently high safety profile. POEM is an established treatment modality, and STAR and G-POEM are first emerging popular options for upper GI subepithelial tumors and refractory gastroparesis. The scope of third space endoscopy procedure is ever expanding, and then with Z-POEM, PREM, diverticular POEM, and poetry already added to the list. And the last decade have witnessed a phenomenal rise of POEM. But the enthusiasm has dampened somewhat because there is a lot of criticism about this reflux, post-POEM reflux. But this post-POEM reflux, what you see in the literature of 40%, 30%, those are all patient. That means if we do reflux studies, there is 40%. But the real life situation, the reflux is only 10 to 15%, what we see. Most of these patients can be controlled with a single dose PPI. And the future of third space endoscopy is bright and exciting. I think new procedures can be done because these are minimally invasive and less expensive also. So in private care settings, a lot of thing depends on the cost of surgery and all. So these are far more less costly than the surgical procedures. Thank you.